All right, good morning. Thank you for joining the Foundation for a Healthy Kentucky's Health for a Change webinar, Maternal Health Matters. I'm Allie Wells, the Communications Associate at the Foundation. Joining us today is Dr. Rachel Saunders, an OBGYN at UK Healthcare. Representative Mackenzie Cantrell was supposed to be with us this morning. Unfortunately, something came up last minute and she is not with us. We are here today, though, to talk about maternal health, specifically the racial disparities in maternal health outcomes. After this webinar, you will be able to understand what the disparities are, what are some of the driving factors, and you will hear about some of the ways people are trying to improve the situation. Before we get started, a little bit of housekeeping. We've enabled the live transcript feature on this webinar. You can control whether you see the closed captioning by selecting live transcript on the bottom of your screen. We invite any questions you may have, just type them in the chat box and we'll address them during the Q&A. First, a little bit about us. The Foundation for a Healthy Kentucky is a nonpartisan, nonprofit organization focused on healthcare access, tobacco use reduction, obesity and diabetes mitigation and prevention, and child health, specifically preventing and mitigating adverse childhood experiences. Much of what we do is in the policy realm, whether on the state level, local level, or even the school or organizational level. So let's get started. I'm going to hand things over to Dr. Saunders.
Good morning, everyone. Let me get my slides pulled up here and then we will get started. Okay. So I was asked to talk to you guys about maternal health disparities, and that's something that is near and dear to my heart because I am a practitioner of women's health, and also being a minority woman myself, that is a patient population I'm obviously very invested in.
Dr. Saunders, we're not, real quick, sorry, we're not seeing your slides.
Oh no, okay, hold on one second, let me see here. Thank you. Let's see, share. Okay, is that better?
Yep, we see them now.
Okay. Okay, so a little bit of an outline. So I'm going to talk a little bit about myself and my journey to medicine. Then I want to transition into talking a little bit about the history of OBGYN. It's pretty complex, especially in regards to Black women. And then talk a little bit about some current issues in medicine that we are facing and things we're doing to address those issues. So about myself, I am a Lexington native, kind of. I was born at the University of Kentucky, but actually grew up in Alabama and then came back to the state for undergrad and just kind of never left. When I'm not doing medical things, which I'll talk about in a minute, I enjoy traveling with my husband, working out, and I've recently gotten into horse riding. So I like to say I'm now officially a Kentucky woman because I'm interested in bourbon and horses. So to talk a little bit about my journey to medicine, I knew I wanted to become a doctor in high school. And so I actually did a presentation when I was a junior, and we had to talk about a potential career. And I had always been interested in service work, volunteering, thanks to my parents, and also had a passion for science. And so as I was exploring different careers, I thought medicine would be a good fit because it would allow me to blend both of those together. And so I, calculated all the years I would need to be in school, including my residency training. And for some reason, I thought that made complete sense and decided this was the path I was going to go down. I attended Berea College for undergrad, so that's what brought me back to the state. And that college just really spoke to me because of its initial mission of educating men, women, Blacks, and whites together. That mission spoke to me, and I loved the campus and the quality of education. After I finished college, I actually anticipated going back home and just being, down south with my family. But I interviewed at the University of Kentucky for medical school and really fell in love with their passion for helping the state of Kentucky and wanted to be a part of that. And so I decided to pursue OBGYN in my last rotation of third year, which the way med school is broken up, you kind of in your third year of med school, do rotations all throughout the hospital, and then you kind of decide or reinforce what you want to do. At the time, I wasn't 100% sure, but after doing my OBGYN rotation, I felt like this was where I was meant to be. I really loved the ability to build patient relationships, to treat patients with medical intervention, and then if that doesn't work, I can then take them and treat them with surgery without having to refer to outside providers. And so here I am today. I decided to stay at the University of Kentucky for my residency, again, just because of that mission that the state had for helping women. And also there's just a very strong sense of community at the University of Kentucky, and I wanted to be a part of that. And so here I am today. I have now been full-time faculty for almost 7 years. It'll be 7 years at the beginning of July. And so just talking a little bit about my journey throughout this whole process, the biggest thing for me has been, or the hardest thing for me, has been kind of fighting imposter syndrome. And in case you guys don't know, imposter syndrome is basically this belief that you are undeserving of your achievements and the high esteem in which you are in fact generally held. And you have this pervasive worry that people are going to discover the truth about you and that you actually aren't as qualified as people think you are, and you're going to be found out and ridiculed. And so in general, you know, when you think about who goes into medicine, the traditional view is kind of the old white man. And so going through medicine and being a woman and being a minority woman, you kind of have a little bit of that. You're waiting for someone to not expect you to be a doctor. Unfortunately, things are starting to change. In fact, our current med school class that's about to matriculate is currently 60% women. So I do think there's a huge shift in not only the makeup of who's going to be doctors, but in terms of gender, but also more racial diversity, because we found that when women are doctors and when doctors are racially diverse, we have better patient outcomes. So next, I'd like to transition into talking about a history of Black women in medicine, specifically Black women in OBGYN. And being a Black woman in OBGYN, it's a little bit conflicting for me. As you'll see, there were a lot of really good surgical advancements made during slavery, but the ways in which they were created were not under the best circumstances. And so first I want to talk about someone named J. Marion Sims, and he is a man who's considered to be the father of modern gynecology. And he's considered that because he developed a lot of pioneering tools and surgical techniques that were related to women's reproductive health. In fact, he was named president of the American Medical Association in 1876. And he also became president of the American Gynecological Society. And that was an organization that he helped found in 1880. So as you can tell, he was very active not only with patients, but on the national scale as well. So this is where things get a little tricky. So Sims' research was conducted on enslaved Black women, and he not only did these experiments and surgeries without anesthesia, but also without their consent. And so a little questionable how we got some of these things, and most medical ethicists, historians would say that, you know, these procedures were kind of ethically bereft, and even though we have great information, the way in which we got it was not okay, which I think everyone would agree with. So the biggest critics of Sims say he cared more about doing the experiments than providing therapeutic treatment, and that he caused untold suffering. And the reason people think this is because he was operating under the notion that Black people do not feel pain. That was a very pervasive notion during slavery. And so he kind of felt justified in doing these procedures without anesthesia and without consent, because, you know, he felt like the Black women didn't feel pain, and so it didn't bother them. Also at this time in the late 1800s, it was considered to be a little distasteful to be a woman's healthcare provider. And so operating on slaves also gave him the chance to come up with really important tools such as the vaginal speculum that we use every day currently as an OBGYN, that probably wouldn't have been created without having slavery. The biggest thing that he pioneered was the surgical technique to repair vesicovaginal fistulas, which again is something that we use today. And this is where a lot of the criticism of J. Marion Sims comes from, is because these procedures he was doing on patients without anesthesia, and he had a lot of complications in terms of infections and people ultimately dying from complications of surgery. So now that we've kind of talked a little bit about where everything started, we're going to talk about some current issues in medicine as well. So first, I want to talk about by describing the CDC Morbidity and Mortality Weekly Report, because this is going to be really important to discuss what's currently happening in medicine. And so basically what that is that the CDC creates something called a surveillance summary. And so they kind of look through population data, and the CDC is constantly looking for things in medicine that we could be improving. And so when they find things, they disseminate that information and they give detailed interpretation of trends and also patterns based on the findings that they're getting from collecting nationwide data. And so in 2019, the Morbidity and Mortality Weekly Report released some very alarming information to the medical community. And what they found is that Black, American Indian, Alaskan Native women are 2 to 3 times more likely to die from pregnancy-related causes than white women. And that they found this disparity not only increased with age, but that income level and education level was not protective. As you guys know, we are in what would be considered a developed nation. So in this country, most pregnancy-related deaths are preventable. And so knowing that there is such a large number of minority women who are having these pregnancy-related outcomes, and also knowing that a large number of them are preventable, really alarmed physicians, because we're trying to figure out what we can do to keep this population safe. And so, as you know, kind of with the history of OBGYN in medicine, there have been racial and ethnic disparities, and also pregnancy-related deaths, and that has persisted over time. When we look specifically at pregnancy-related deaths here in the United States, per 100,000 live births, and this is going to be called the pregnancy-related mortality ratio, or PRMR, for Black, American Indian, and Alaskan Native women older than 30. It's 4 to 5 times as high as that for white women, so very, very high. And even in states with the lowest PRMRs, women with higher levels of education are not protected, as I talked about earlier. So the CDC created a pregnancy-related mortality surveillance system, also known as the PMSS. And this organization, or this tool, was created to define pregnancy-related death. And so they define that as the death of a woman during pregnancy or within 1 year from the end of pregnancy due to a complication of their pregnancy. So that can either be directly related to the pregnancy, a chain of events that was initiated by pregnancy, or the aggravation of an unrelated condition by the physiologic effects of pregnancy. So basically, if we can tie back that death within the first year to their pregnancy, then we consider that to be a pregnancy-related mortality event. So when they looked at the MMWR in 2019, they actually found that the pregnancy-related mortality ratio increased from 15 to 17. So we're definitely going in the opposite direction for 100,000 births. And then when we kind of broke down those pregnancy-related mortality ratios by race, we found that non-Hispanic Black, their ratio was 40.8 compared to, the normal baseline. Non-Hispanic American Indian and Alaskan Native women was 29.7 compared to the baseline, which remember is 17. Asian and Pacific Islander was 15. And white was 12.7. So you can see we've got a lot of work to do specifically with the Black women community and also the non-Hispanic American Indian and Alaskan Native community. Those two, compared to our baseline of 17, have a much higher rate of our pregnancy-related mortality ratios. Oh, I'm sorry, Hispanic women is at 11.5. And so, as we talked about, our Black and American Indian and Alaskan Native women experienced much higher PRMRs than all other racial and ethnic populations. And when you do the math, that's 3.2 and 2.3 times higher than the PRMR for white women. And as you kind of look at the population as they get older, that gap just continues to widen. For women who are over the age of 30, the PRMR for Black and American Indian and Alaskan Native women was 4 to 5 times higher than it was for white women. And for women with a college degree, again, the pregnancy-related mortality ratio for Black women was still 5.2 times higher than that of their white counterparts, even if that counterpart did not go to college. And when we look at some of the events related to the pregnancy-related mortality ratios in women, the biggest things that contribute are going to be cardiomyopathy, which is a heart problem that you can develop in pregnancy, and that leads to heart failure. Thrombotic pulmonary embolism, so that is when you get a blood clot in your lungs related to pregnancy. And hypertensive disorders of pregnancy, which is high blood pressure in pregnancy, specifically that you develop because of the pregnancy. And these contributed to more pregnancy-related deaths among Black women than among white women. When we look at other causes of maternal mortality, hemorrhage and hypertensive orders of pregnancy, and hemorrhage is when there's so much bleeding that eventually you pass away, contributed to more pregnancy-related deaths among American Indian and Alaskan Native women than white women. And when you kind of look at the last time we really looked at population data and kind of the early 2000s to now, these disparities were actually persistent and did not change at all. And so I wanted to talk a little bit about some examples, because I think sometimes it's easy to just see data and say, okay, but what's really happening in the community? And these are actually a couple of famous examples of women who suffered from health disparities. And so, as you know, Serena Williams is a very famous tennis player. When she went in for her delivery, she ended up having a C-section, and she's very open about the story. She actually had a known history of deep vein thrombosis, or a condition where you're predisposed to getting blood clots, especially in your legs. After delivery, which again was a surgery, so your risk of blood clot is already high because you're pregnant, and now you've got a double whammy because you're post-operative. And she had persistent shortness of air and some persistent pain after delivery. She actually alerted the nursing staff and initially was kind of dismissed as this is normal post-operative things, don't worry, it's okay. And fortunately, she was educated enough to know to advocate for herself and to not take no for an answer. So she eventually was able to get some duplex imaging of her legs, where basically they do an ultrasound to look for blood clots in her legs. They didn't see any blood clots, but fortunately Serena was smart enough to continue to advocate for herself, and they ordered a scan called a CTPE that looks at your lungs and looks for blood clots in your lungs. And they actually ended up finding that she had a pulmonary embolism, and she was able to be treated for that, which is a blood clot in the lungs. And so this is just a great example of, you know, someone who's very well educated, knew a lot about their own personal health, and was able to advocate for themselves. But think about all the people who don't know that they can take no for an answer, or who don't even know that maybe something's wrong. And they take it at face value when a healthcare provider says what you're feeling is a normal change in pregnancy. And the other example I wanted to bring up was Dr. Chaniece Wallace. She actually was a pediatric resident at the University of Indiana. And she developed preeclampsia with severe features, which is a high blood pressure related disease in pregnancy, but it becomes so severe that it can affect your liver. And so her liver became so swollen that it basically kind of broke open and she bled to death. And so she had multiple surgeries after being delivered via C-section, and she ultimately died of those complications. And so I bring up these two examples because these are two very high profile women who knew to advocate for themselves. And Dr. Wallace, you know, knew about the risks of pregnancy and still was not able to survive her pregnancy. And so I use these examples because it really makes me worried about the common women, or that, everyday women who may not know that, again, she can advocate for herself. So I hate, doing talks and saying doom and gloom things and then not giving ways that we can help, or at least talking about what we're doing to help rectify the situation. So fortunately, the CDC took their morbidity and mortality weekly report very seriously, and they're currently on a national level trying to fix these issues. And so they are right now awarding more than $45 million over the course of 5 years to support the work of MMRCs through a program called Enhancing Reviews and Surveillance to Eliminate Maternal Mortality, also known as the ERASE MMRC program. I do know that the University of Kentucky has some investigators that are applying for these grants to help study that. And so the investment will provide over about $9 million a year to 24 recipients representing 25 states. And so this money is going to go towards figuring out ways to figure out why this is happening, and also to develop steps to address the issue. Other ways we can begin to address the issue. The first thing is just to collect more data and improve the data collection process so that we can see what's happening in real time. Because a lot of times we get this information, but this is something that's been going on. And so it's hard to tell if things are getting better or worse until we kind of stop and look. And unfortunately, the CDC tends to be a couple of years behind by the time they, publish data. And so at that point, we're already scrambling to play catch up. The biggest thing that we're doing here at the University of Kentucky, not only do I practice medicine, but I also teach medical students and residents, is trying to address implicit bias among medical professionals. Because if we can attack this piece, then I think that will help make patients more safe. Expanding postpartum care is going to be very important, and I'll talk a little bit about how we can do that. And also expanding medical coverage and support for pregnant and postpartum women will also go a long way to help with these disparities. So I quickly wanted to touch on implicit bias. And so this is going to be an attitude, stereotype, and belief that can affect how we treat others. It's important to know that implicit bias is not intentional. It's just our brain is used to filtering out a lot of information very quickly. And so this is a way to kind of filter information quickly. You see a person and you put them into a category. And unfortunately, you treat that person based on the category that you unconsciously put them into. And so different categories could be race, ability, gender, culture, language. And we found that in early childhood settings, implicit biases can affect how providers perceive and respond to children. And that can actually lead to unfair differences in the use of exclusionary discipline practices, such as suspension and expulsion. And so we found that minority children tend to get in trouble a lot more in elementary school. And we think a lot of that is due to implicit bias from teachers. And so this is a very interesting study that was done addressing implicit bias from the perspective of the patient and how they felt they were being treated by providers, and also how they felt other groups of ethnic minorities or majorities were being treated by providers. And so the question was asked, when going to a doctor or healthcare clinic for healthcare services, do you think most African Americans receive the same quality of healthcare as whites, a higher quality of care, or a lower quality of care as most whites? And so the green is going to be lower, purple is the same, and this peach is higher. And so when white patients were asked that, they actually felt like a large portion of African American patients received the same amount of care. When you asked Blacks, a large portion of them actually felt like they were receiving worse care, which is really important because one of the things we're also addressing is this pervasive mistrust of the Black community with the medical system, which is very justified given the history of medicine and Black people, but it's something that we're currently trying to work on. When Hispanic patients were asked, again, the majority felt like the care was the same. And so in total, kind of when you average everybody, the majority felt like the care was the same. The next question was, when going to a doctor or health clinic for healthcare services, do you think most Latinos receive the same quality of care as whites, a higher quality of care, or lower quality of care? And again, in the white patients, it was thought to be about the same. and Black patients, again, thought to be lower. In the Hispanic population, thought to be lower, and overall total, again, the average is about half of the people thought that the care was about the same. And so other things we can do to help. So one of the things we're doing at the University of Kentucky is really trying to put an emphasis on social determinants of health. And we are putting all of our students and faculty through implicit bias training. And we're addressing medical curricula that was traditional, very stereotypical and racist, and really trying to rework that. And so our hope is to graduate the next generation of doctors that are not completely free, but at least know to address their own implicit biases and are learning accurate medical information and not stereotypical things that are promoted. Other ways that you guys can help are going to be to contact your local, state, and federal legislators to advocate for better and expanded healthcare coverage for patients, especially in the postpartum period, because that's when pregnant patients are most vulnerable. And do you guys have any questions? If you throw them in the chat box, I would be happy to answer them.
Yes, put your questions in the chat box. We are going to hold, they'll be there the whole time, but we're going to hold until the Q&A portion. We do have Representative Cantrell here. She is going to be talking about House Bill 174 and a recent effort in Frankfurt in the past legislative session to improve maternal health outcomes. So here she is. Oh, we are having, there you are. We couldn't hear you for a second, but we can now.
But thank you all for having me. And I think Dr. Saunders' presentation leads really well into what I have to say about recent efforts in Frankfurt to expand Medicaid coverage for postpartum women. So I'll tell you a little bit about how this effort came about. So I am a state legislator in the House of Representatives, and I represent an area in Louisville, in the south end of Louisville, around Iroquois Park. And I've been in the legislature for 6 years, and this will be my last year in this stint that I'm doing right now in the legislature. I'm not running again. And I'm a Democrat, and I'm not saying that to spark some sort of political conversation. I'm saying that to give a little bit of context about this bill. So ever since I've been in the legislature, we have seen an onslaught of anti-abortion measures being adopted in Kentucky. And along with that, some of us who have been consistently against these measures have said, okay, if you're going to force women to give birth against their will in Kentucky, you're going to have to make it you're going to have to make it where they're going to survive. And our infant and mortality numbers and maternal health numbers in Kentucky are not good at all. And when you compare a very safe medical procedure such as abortion to giving birth in Kentucky, it doesn't even compare. And that's just, and that's just the sort of the surface level view of it. But a group of the House women Democrats 2 years ago set up an agenda, a platform, a plan of legislation dealing with infant and maternal health in Kentucky. And that was the genesis of these pieces of legislation. It was, if you're going to force women to have children, you have to make it where they have a chance at survival and thriving in our state. And if you know me very well, I don't have children, and I'm a lawyer. I practice employment law. I'm on the Judiciary Committee. I'm not an expert in this area at all. And I was kind of wondering, where my place was in all of this. So, we came up with about 20 bills, and everybody sort of took one or two. And some of my colleagues were a lot more in the forefront of this effort than I was. And I took the two most simple pieces of legislation. I took what ended up being House Bill 173 in this year's legislative session, and that was to approve Medicaid coverage for behavioral health for postpartum mothers. And then House Bill 174, which we're mostly going to be talking about today, which is expanding Medicaid coverage for up to 1 year for postpartum mothers. And I took those pieces of legislation because they're very simple language wise, 1 page, 7 words. And I'm going to pull it up. All of House Bill 174 was striking some language and adding in a sentence that said pregnant women, and adding the language new mothers up to 12 months postpartum and children up to age of 1 shall be eligible for participation in the Kentucky Medical Assistance Program and that's if they qualify under the other guidelines relating to income and other types of eligibility. So it was really, I said this all throughout the bill's progression, is it's a 7-word change that's going to make a bigger difference than anyone could ever imagine in our state. And so to my surprise, and I say that because with my background, you file all sorts of pieces of legislation about all different sort of things. Your constituents approach you about different issues. You have your own issues that you fought for several years, and then new things come along, and you kind of develop just a little toolbox of legislation of things that you promote, and you never know which one will gain enough steam to go through the legislative process. And I have found that out over the years. It's never the one that you think it'll be. Might not even be the one that you would have picked, but one gets moving and you get behind it and you get excited and you go with it, the whole way. And that's what happened. The behind the scenes story is that when Congress passed ARPA, the American Rescue Plan Act, there was sort of a language and then a sort of a carrot placed in that piece of legislation for states to adopt expanded Medicaid coverage for postpartum women. And that's through what's known as a SPA, or a state plan amendment. And CMS, the Centers for Medicare and Medicaid Services, have issued guidelines on how to adopt that. So this all started with ARPA. So ARPA has made it a lot easier for states to adopt this piece of legislation and this policy of covering women 1 year postpartum during that time that Dr. Saunders mentioned under the CDC definition, where women are really vulnerable during that time period, in that postpartum period, and it's going to count against your maternal health numbers if they have complications during that time period. So according to the Kaiser Family Foundation, 8 states have either implemented or are planning to implement expanded Medicaid coverage for 1 year postpartum. They had us in the planning period, even though we do have the authorization from the legislation that was passed earlier this year. So I added those 2 groups of numbers together to get the 28, even though some states are in a little bit of a different progression than others. So through this ARPA plan, the chairwoman of the Committee on Health and Family Services came to me and she said, "Oh, I've been reading about, how ARPA is making it easier for states to adopt plans for expanded postpartum Medicaid coverage, and I saw that you have a bill on that. Do you want me to hear it? Do you want to have it heard?" And I was thinking, oh my gosh, yes. You say nothing but yes, right? But I really didn't know a lot about this. So I've done all sorts of research and to prepare for the committee proceedings. And she said, "Oh, it doesn't matter. I'll help you through it." And I love that part of the story, because this became an effort by women to get this policy passed. So Chairwoman Kim Moser, this would not have happened without her. It became a very bipartisan effort and became a real effort from women in the face of a lot of, in a male-dominated legislature, a lot of people not understanding why this policy was so important. So it went through committee and passed through the House in its original 1-page, 7-word version. And that was the way I liked it, right? It goes over to the Senate and it becomes sort of a Christmas tree. It gets heard in committee and it turns into this 40-page bill with all this other language from different pieces of other people's bills that they wanted. And I'm like, okay, we're just going to go with it. We're going to trust the process. We're going to roll with it, let it ride. And it passes the Senate committee and it gets a lot of amendments placed on it. And that's the story of House Bill 174. And if you're familiar with the legislative process, you know that's not a unique story. I think because it's my last year in the legislature and I'm not running again, I got really, really invested in a bill, making it all the way through the process, so that I have some sort of something to look back on that was, favorable in my time in the legislature. And like I said, I wouldn't have picked this one, but this one is something to really, really be proud of. So what happened the last 2 days of the legislative session is this could wait till the end because it was not very controversial and they knew the governor would sign it. So they sort of waited until the end to pass it fully. It became a part of language in a bill that passed, and it didn't pass, as my bill with my name on it, which was not important to me at all, but it passed in the form of Senate Bill 178 and had a lot of other provisions in it. And I think it was about a 50-page bill. But one of the first lines of that new law is the postpartum Medicaid coverage that we can all be really proud of. So that's the story. The governor signed it about a week or two later, and it's going to be the law of Kentucky. I don't think it had an emergency clause on it. Let me look really fast. It doesn't look like it did. So it looks like that'll be the law of the land here in a couple months, and it'll take, some implementation. But overall, it's a great policy. It was a great thing to be a part of. It was a great thing to see everything work the whole way through after 6 years in the legislature. And it's something that's going to make a big difference. I was looking at some of the maternal health numbers, and from 2013 to 2018, 284 women, mothers, died within that year time frame set out by the CDC, and they had different categories classified as natural, accidental, homicide, and suicide. So thinking about all of those different categories, not just natural causes, but if you look at homicide, if it was a domestic violence related homicide, or suicide when it comes to the mental health crises that we're dealing with right now. If someone is seeing a doctor on a regular basis and you have people screening for domestic violence and someone's mental well-being, that can move the needle on all of those numbers, right? So it's a really sound policy that is tackling multiple problems at once. One of the other numbers that I found that was quite shocking from the Kentucky Health and Family Services maternal mortality review from 2017 was 46% of maternal deaths were related to substance use disorder. So we've done a lot in the legislature the past few years to sort of destigmatize and encourage mothers who are expecting to seek substance use disorder treatment as soon as possible. And then, like Dr. Saunders mentioned, 78% of those deaths were deemed preventable. And that's the most important part of this, is that especially low-income women, if they can afford to seek care and they're not heading to the emergency room thinking, how am I going to feed my children once these medical bills come? How am I going to take care of myself? Am I going to have to file bankruptcy? If those thoughts are sort of off the table, then mothers are going to seek the care that they need, and preventable care is you save so much money in healthcare costs the earlier that women seek medical care, and going forward you're going to have a lot better health outcomes for these women. I'll take questions as well in the question and answer portion, but that's mostly all that I wanted to present, was just the journey around this bill, how happy we all should be about it, and looking forward to what's next for Kentucky women and Kentucky mothers.
Thank you so much, Representative Cantrell. That was great information. Now we are going to move to the Q&A. We do have a couple in the chat, so I'll start. We have one person wanting to know, and I believe this is for Dr. Saunders, is there any data collection on birthing injuries that have not caused a death?
I'm guessing that question is for a national level. Hospitals do track outcomes for patients that aren't mortality. I don't believe that is collected at a national level, but we are compared to other hospital systems that are similar to us. So for example, the University of Kentucky would be compared to all university hospitals throughout the country. So hopefully that answered your question. If not, reframe it. I'm happy to answer it again.
We have one person wanting to know, do you have any recommendations for good sources of implicit bias training that could be used by practitioners across the state?
That's a really great question. Ours is usually set up through the University of Kentucky, but I do know that UCLA has a very nice quiz that can at least get you started with just identifying personal biases that you may carry, and you can go from there. But I would also encourage you to ask your employer as well, because I think that is something that honestly every healthcare practitioner should have.
We have another person wanting to know, is there good sources of data to assess trends of maternal experiences in Kentucky? I've used birth records, which are fantastic because of the number of births, but some have notable limitations, like lack of specificity and challenges to access the data.
That's a really great question. Unfortunately, a lot of the outcomes that aren't kind of public property are protected under HIPAA. So unless we are doing a research project where we can get special permission to mine through some of that data, I don't know of another really good source.
We have someone wanting to know, do you have any suggestions for enrolling women throughout the state in different prenatal programs that Medicaid offers? They say not all OBs are set up with case management resources to assist patients with different challenges that the social determinants of health identify.
It's a really great question. I am a faculty member in our kind of lower income clinic that the residents manage primarily. And I also am a lot of times struggle with kind of support to get those patients enrolled. So the short answer is I don't.
Someone did put in the chat that the March of Dimes has good implicit bias training. So I just wanted to note that for everyone. And then someone asked, how does someone get involved with the Foundation for a Healthy Kentucky? We'll get to that at the end, don't worry. If there are no more questions, Dr. Saunders, Representative Cantrell, thank you so much for presenting with us today. That was a great amount of information.
Thank you.
Thank you.
Now I'm going to turn things over to our Vice President of Communications, Ashley Brower. She's going to talk about some resources we have available for you all.
Thanks, Allie. I want to go ahead and share my screen with everybody. So we're so happy to host this webinar today. And just last week, we launched a campaign that is an educational campaign talking to expectant mothers in Kentucky about COVID-19 and the risk of getting the virus and also the vaccines. And I want to share with you all some of the findings from our focus groups. We talked to women who were pregnant from across the Commonwealth and found some really interesting themes throughout. So obviously the health of the baby is of course a top priority. It is driving all of their decisions. And what we found is there's a lot of misinformation. There's a lot of confusing and conflicting information. And what they expressed to us is that they found that a lot of the existing messaging is either patronizing or shaming. They felt like there's a lot of shame that can go along with being pregnant. And are you doing this? Are you not doing this? And this is just another thing. So they are very sensitive in how they're approached with this information. And they're not blindly following any advice from really anyone. But if there is someone that they are placing more trust in, it is their own healthcare provider, their own OB, and it's certainly not federal health authorities, and it's to an extent not state health authorities either. So what we found was that there really was a greater fear from potential side effects of the vaccine versus either short or long-term risks of getting the virus instead of getting the vaccine. Many of you know that could be preterm labor, it could be death, it could be preeclampsia. And many of the mothers who had not been vaccinated actually were movable when they started to learn more about, what the research is showing, especially if it was given in a very objective, non-confrontational way. They do overwhelmingly believe that the vaccine was rushed. They are nervous about long-term side effects, and they don't understand how the mRNA vaccine actually works, in that the baby doesn't get the vaccine. It does not go through to the placenta. The baby only receives the antibodies from the mom. So the moms told us that they want to have reliable sources of information, and they want to sit down and talk with their doctor about it. And they most of all want to have an individualized decision where they feel confident in making that decision for themselves and for their baby. They don't feel like they're getting adequate information, and they want it to be more than just this is recommended for you. They want a whole conversation around it. So we built this campaign, and our call to action is simply talk to your doctor. Find out what it means for you and your baby and your pregnancy, your family, and do what's right for you. And that's just based on what I just shared with you, what those moms told us over and over. So a couple of examples of what we are putting out there on social media. We've got some educational posts that have different facts that it's very possible moms or the public in general do not know. Women who get COVID-19 are 40% more likely to develop serious complications when they're pregnant. That's big. There are some big risks to getting the virus. And so we wanted to balance some educational facts, and hopefully these will be a starting point for those conversations with their doctors. And so you'll see these on our social media. We also have them available to download. And if you all would like to share them with your clients, with your patients, we would love that. So I wanted to also share with you a couple of the videos. We had a couple of new moms who got the vaccine while they were pregnant, do testimonials, and then a couple of Kentucky OBs as well. So here we go.
Getting pregnant during a pandemic is one thing I'll never forget. My decision to get the COVID-19 vaccine was about the safety and protection of my child. My advice to you would be to go and talk to your doctor to see if the shot is the right thing for you.
Emmy has been in the 99th percentile for all of her growth, her entire life, basically. Yay! I got the COVID vaccine when I was in my second trimester. The scariest thing was the unknown. Now that we have all this research that shows that it is safe, I think it is wise for someone to make the best decision for them and consult their OBGYN.
My name is Wendy Jackson, and I'm an obstetrician gynecologist serving the women of Kentucky. So moms and physicians are on the same team when it comes to growing a baby. It's essential for pregnant patients to engage in conversation with their physicians at prenatal visits about the COVID-19 vaccine. You deserve to have the facts about the risk and benefits of the COVID-19 vaccine to keep mom safe and to keep baby safe.
COVID-19 vaccine is especially recommended for pregnant women because when you're pregnant, your immune system is not as strong. My advice to you as an expectant mom, make an appointment with your doctor, write down your questions, all of your questions, because it's easy to forget once you get in the room. And specifically, what are the concerns you might have around COVID-19 vaccine?
We also created some one-pagers that if you all wanted to print out and put on a bulletin board or share with your clients, with your patients, they are just very straightforward with some of the facts. And we've also linked everything on our website. It's all at healthy-ky.org. And then what's right for you is the page. And, we really just, in partnering with the Kentucky Association of Health Plans, wanted to get the word out just to not to scare anybody, but there are some big risks here if you get COVID when you're pregnant. And, what we just learned in those focus groups is that I don't know that folks really understand that those risks are potentially greater than side effects from the vaccine. And so we hope, and I see Andrea, I will post the link here in the chat box, but would love for you guys to help us either share on social media or share directly with your clients. And if we can be of any further help, please let us know. That's all I have. Allie, I'll toss it back over to you.
Thank you, Ashley. And again, like Ashley said, all of those resources are available on our website, healthy-ky.org. Be sure to follow us on social media, reach out with any ideas or questions you may have about future Health for a Change trainings. You guys have been a great audience today. I really appreciate you all being here. This presentation will be available when it's done. I will send it out via email and you'll have the video and all of that. Feel free to share it with everyone else in your community. Thank you, and I hope you have a great rest of the day.